మా కళ్ళు తెరు, నాలుగు చూపించు, నాలుగు చూపించు, నాలుగు చూపించు, నాలుగు చూపించు.
హలో శ్రీకాంత్, స్క్రీన్ మూవ్ అవుతుందా?
లేదు, ఫుల్ స్క్రీన్ కూడా రావట్లేదు, మామూలుగా ఉంది.
నాకు ఫుల్ స్క్రీన్ వస్తుంది.
ఒక్కసారి ఎగ్జిట్ చేసి అదే మళ్ళీ షేర్ చేయండి. ఫస్ట్
ఇప్పుడు
ఫుల్ స్క్రీన్ రావట్లేదు, మామూలుగా అలాగే ఉంది. మీ మోడరేటర్ జాయిన్ అయ్యాడు.
ఇప్పుడు శ్రీకాంత్, ఇప్పుడు అంతేనా?
ఫుల్ స్క్రీన్ రావట్లేదు, స్లైడ్స్ మూవ్ చేయి.
స్లైడ్స్
పోవట్లేదు, అలా ఫిక్స్డ్ గా స్క్రీన్ దగ్గర ఉండిపోయింది.
మళ్ళీ లాగిన్ అయితే ఒక నిమిషం.
జయరామ్, ఏంటో అబ్బాయి పరిస్థితి? 11 బాగానే చేస్తాడా?
అంటే ఇప్పుడు దాకా కేసు ఏం చేయాలి, నైట్ డ్యూటీలే కదా.
ఓకే ఓకే.
కేసు పైపించు. అదే 7 o'clock కేసు స్టార్ట్ చేసాం, తను చేసి ఇంట్రెస్ట్ చూపించలేదు. 7 o'clock నేనే వచ్చాను, ఓటీ లోపల కూడా రాలేదు భయ్య.
అవునా? మరి అనస్థీషియా ఫెలోషిప్, మరి రీజనల్ అనస్థీషియా,
అదే
రీజనల్ అనస్థీషియా ఫెలోషిప్ పని, ఐసీయూ కూడా కాదు.
మొన్న ఫస్ట్ హాఫ్ అన్ అవర్ మనకి, అదే ఫస్ట్ 1 year మనకి కొంచెం ఒక ఇచ్చింగ్ అంటూ ఉంటుంది కదా ఓటీ లోపలికి వెళ్ళాలని.
అవునవును అవును.
చూద్దాం, మామూలు సార్కి కోర్టులో వేసాను బాల్, చూద్దాం.
అవును కరెక్ట్, ఏదో ఫ్రెషర్ అది అడిగారు కదా. వెళ్ళిపోతారేమో సార్ అంట. ఓకే. అందరికి కూడా చెప్పాలి ఒకసారి, నేను మర్చిపోయాను.
శ్రీకాంత్ స్క్రీన్ విజిబుల్ ఉందా?
స్క్రీన్ విజిబుల్, స్లైడ్స్ అయితే ఏదో మూవ్ అయ్యాయి ఇప్పుడు. కానీ ఫుల్
అవుతుందా?
స్క్రీన్
మూవ్ అవుతున్నాయి సార్, మూవ్ అవుతున్నాయి.
ఫుల్
Sir,
స్క్రీన్
more-
మరి ఫుల్ స్క్రీన్ మరి ఏం ప్రాబ్లం తెలియట్లేదు.
ఈ పవర్ పాయింట్ ఆ సిస్టమ్ లో ఉన్నదేనా లేదంటే ఎక్కడి నుంచైనా డౌన్లోడ్ చేసావా?
ఈ సిస్టమ్ లో
అంటే ఐ మీన్ వేరే సిస్టమ్ నుంచి దీనికి మెయిల్ పంపించుకోవడం అలా ఏం లేదు కదా?
లేదు, ఎందులో
జనరల్ గా అవైతే ఎనేబుల్ ఎడిటింగ్ నొక్కాలి, అప్పుడు వస్తాయి మొత్తం.
ఎందులో
సాఫ్ట్వేర్ చేంజ్ చేయలేం.
ఏం
స్టార్ట్
చేద్దాం?
చేస్తాను.
స్టార్ట్ చేసేద్దాం. Good morning, all. Today I am going to discuss a topic called post-operative delirium, which we are going to see commonly. Delirium is not a new phenomenon; it is an age-old phenomenon. It is even described in the history books. It is derived from the Latin word delirare. It means deviation from the normal path. As per definition of WHO, delirium is defined as etiologically non-specific organic cerebral syndrome characterized by the concurrent disturbances of consciousness, attention, perception, thinking, memory, and psychomotor behavior, emotion, and sleep-wake schedule. The disturbances in all these parameters. Duration is variable, and the degree of severity ranges from mild to severe. And American Psychiatry Association also described in the DSM-5 regarding delirium. Delirium is a mental state with confusion, disorientation, and not able to remember anything. It generally starts suddenly in most of the times, and most of the times it is temporary, in treatable condition. Sometimes it is even fatal. Delirium in day-to-day life, we come across in different places, in emergency, in ICUs, in post-anesthesia recovery rooms. But today we are discussing only post-operative delirium. Post-operative delirium commonly occurs in the post-operative days from day 1 to day 5 generally. Although incidence in general surgical population is 2 to 3%, it has been reported to 50 to 70% in high-risk groups. In addition to occurrence of post-operative delirium, is also associated with considerable increase in morbidity, mortality in the health sector and healthcare burden also. In general surgical population, on average age, the incidence is 2.5 to 3%. In elderly 60 to 70 years group, the incidence of post-operative delirium is relatively high. It is 10 to 20%. When we do surgeries in the lower extremities or upper extremities, the incidence is 2.5 to 3% when compared to high incidence in truncal and abdominal surgeries and spine surgeries, which is around 10 to 30%. When we do emergency surgeries, the risk is around 20 to 45%, which is 1.5 to 3 times higher than the non-emergency elective surgeries. Complex surgeries requiring post-operative ICU stay having 20 to 30% risk of post-operative delirium. Especially in orthopedic cases, neck femur repair is associated with 70% of the post-operative delirium. Chances of post-operative delirium can be seen in 70% cases. Regarding burden, increased hospital stay of the patient by 2 to 3 days because of delirium, and ICU stay is prolonged by 1 to 2 days. And post-op 30-day mortality was 7 to 10% in delirious patient compared to 1% in non-delirious patient, which is highly significant. Proportionately increases the healthcare cost. Coming to differential diagnosis of delirium, delirium should be
I
differentiated.
think the slides are not moving.
Okay. Madam, ఇప్పుడు
ఇప్పుడు కనిపిస్తుంది.
Okay. We should differentiate the delirium, which is very dangerous, from other differential diagnoses like dementia, depression, and psychosis. We should take help of the psychiatrist if required. Delirium can be of three types. It can be hyperactive. In this situation, patient will be very agitated, pulling IV lines, pulling catheters, moving away from the bed. And it can be hypoactive, which is more common. Patient will be looking like comatose state, which is more common and more dangerous. And there will be mixed population which having both hyper and hypoactive. Coming to pathophysiology of the delirium, it can be due to neuroinflammation, it can be due to alteration of the neurotransmitters availability in the brain, and it can be due to subclinical cerebrovascular accidents. Coming to first thing, neuroinflammation, systemic inflammatory mediators are increased significantly after surgery and remains high during the post-operative period. It has been reported that high elevated CRP levels, interleukin-6 are highly elevated in the perioperative and post-operative period in many of the delirious patients. Preclinical studies have demonstrated that peripheral inflammation can lead to loss of the structural and functional integrity of the blood-brain barrier, which subsequently translocate the inflammatory mediators into the CNS and cause delirium. The accumulation of inflammatory mediators then result in loss of the synaptic plasticity and neuroapoptosis and impaired neurogenesis. Previously, it is thought that after surgery, after general anesthesia, amyloid beta deposition is seen in many of the brain areas, and later on it is proved that it is wrong. However, the study reported that multiple surgeries in anesthesia are associated with significantly high risk of the abnormal cortical thickening. Coming to disturbance in the neurotransmitters, which leads to occurrence of delirium, acetylcholine is the important neurotransmitter that present in all of the neuronal tissue. ACH is thought to be believed in neuroplasticity and is present in several neuronal pathways responsible for the attention and memory. In many of the delirious patients, there is a lower acetylcholinesterase in perioperative period seen. They are more prone for delirium. Similarly, another observation study in older patients undergoing non-cardiac surgeries also found that delirium has lower post-operative acetylcholinesterase activity. Several dopamine receptors and transport gene polymorphism have been found to alter the risk of the post-operative delirium, confirmed in the recent meta-analysis. Two small studies have shown that patients with delirium have altered monoamine metabolism, and although this is not confirmed to be independent risk factor of the multivariable analysis. Coming to subclinical CVS, which can be lead to delirium in post-operative period, it was reported that diseases with increased risk of cerebrovascular accidents like uncontrolled hypertension, patient with AF, and the patient having previous history of stroke are at increased risk of post-operative delirium due to having clinical or subclinical cerebrovascular accident. It should be ruled out by radiological imaging. A small cohort study of the lung transplant patient has showed that for every 10 mm reduction, the cerebral perfusion pressure is associated with the double risk of the post-operative delirium. Another study retrospectively analyzed that association between the cerebral perfusion pressure and delirium and found that cerebral perfusion pressure above the autoregulator limit is an independent risk factor for the development of the post-operative delirium. Coming to management plans, we should predict the patients who are at the risk of the development of delirium. We have to optimize the patient's prior surgery by different methods. We have to maintain these patients intraoperatively, and we have to diagnose these patients, and we should differentiate this patient from others as early as possible. And finally, we have to treat properly. Even the treatment options are very less. Coming to the risk factors to develop delirium can be divided into non-modifiable, potentially modifiable, and modifiable. Non-modifiable risk factors include extremes of age, previous history of delirium, previous depression, comorbid status burden, and previous CVS, terminal illness, previous surgeries and emergency procedures, and especially cardiothoracic surgeries. They are all non-modifiable risk factors. And the potentially modifiable risk factors include functional impairment, sensory impairment like hearing and vision impairment, duration of anesthesia. We can decrease the duration of anesthesia so that we can decrease the occurrence of delirium, and alcohol abuse, malnutrition, and excessive blood loss is proportionately increase the chances of delirium. Coming to modifiable risk factors, acute severe illness and uncontrolled pain and excessive instrumentation during surgery, hypodermic events, use of restraints, and multiple polypharmacy medications, IV infusions, impaired oxygen, hematological abnormalities, biochemical abnormalities, renal failure, renal abnormal renal parameters, and respiratory complications are the modifiable risk factors. Coming to preoperative risk reduction strategies before surgery, avoiding perioperative polypharmacy is the important factor in decreasing the chances of occurrence of the delirium. Because many of the patients are having, old age patients, they are having on multiple medications, we should adjust the doses. If there is chance, we should decrease the number of drugs that we are using. Polypharmacy is commonly associated with advanced disease and presence of multiple comorbidities, both of which increase the risk of post-operative delirium. Polypharmacy itself is the independent risk factor for the occurrence of the delirium. Second thing is avoid excessive fasting. Even though we allow clear fluids 2 hours before surgery, practically many of the patients maybe fasted more than 6 hours for clear fluids because of the scheduling, because of the busy of the surgeon or busy of the OT. So we should try to give clear liquids 2 hours prior surgery so that the prolonged fasting results in dehydration, unnecessary use of IV fluids, and other perioperative complications such as nausea and vomiting. A large cohort study found that fluid fasting for more than 6 hours is independent risk factor for development of post-operative delirium with odds ratio of 10.6. So we have to decrease the pre-surgery fasting, especially for the clear fluids, restricted to 2 hours. Come to the third thing, comprehensive geriatric assessment. As delirium is more common in old age patients, comprehensive geriatric assessment is a multidisciplinary approach to systemically evaluating and addressing the often complex care needs in the older patient. In addition to expert-led medical reviews, patient functional, psychological, and social issues are explored before surgery, and individualized plans are made in advance in order to optimize patient for the surgery and post-operative recovery. There is now evidence that CGA-based perioperative care improves post-operative outcomes. Coming to most important thing, the pain, which is the most common cause of the occurrence of delirium. The pain management preoperatively. Preoperative pain management. Several observational studies have found that preoperative pain is associated with 1.5 to 3 times higher risk of development of post-operative delirium. Pain imposes a direct cognitive burden, triggers acute stress response, and increases high risk of post-operative complications such as atelectasis and other stress response, and there is an increased chance of delirium. There is a systemic review on the perioperative use of facial area block for neck of surgery, neck of femur fractures. Because if they give prior surgery, there is a decreased chance of occurrence of delirium. Early repair of the femur neck of fracture is also reduced risk of delirium, although there is limited evidence available regarding this topic. Coming to depth of anesthesia monitoring, initially thought that EEG monitoring and proper maintaining the proper plane of anesthesia during sedation or in general anesthesia is important in developing delirium. But recent studies showed that monitoring of EEG has shown no benefit when compared to other studies. Use of multimodal opioid sparing analgesia. So pain is the most common complication after surgical procedures. Observational studies have found that higher post-operative pain score is associated with increased risk of delirium. Conversely, the use of opioids have also been associated with increased risk of post-operative delirium. This suggests that use of multimodal opioid-sparing analgesia regimens is likely to be optimal management option in minimizing post-operative delirium. Coming to use of paracetamol and NSAIDs. NSAIDs and paracetamols are commonly used as a part of multimodal analgesia after surgery. Moreover, it has been suggested that these drugs may prevent post-operative delirium by directly elevating neuroinflammation. Hello, am I audible? Hello.
Yes, sir.
NSAIDs are a class of drugs which inhibit cerebral activity of the cyclooxygenase enzyme. In animal studies, both ibuprofen and pericoxib have been shown to reduce the neuroinflammation secondary to the cerebral ischemic perfusion and neuroinflammation secondary to remote. Paracetamol is a central acting analgesic and antipyretic inhibition of cyclooxygenase enzyme in the CNS. In animal models, paracetamol decreases the inflammation and oxidative stress in the hippocampus. In the recent clinical trial, cardiac patients, regular post-operative paracetamol administration reduced the risk of delirium from 28% to 10% after use of paracetamol in the perioperative period. Coming to dexmedetomidine, a new drug, dexmedetomidine is a highly selective alpha-2 adrenergic receptor agonist. Although it was initially licensed for sedation in the ICU, more recent studies have suggested that it is having neuroprotective effects, so it can be used in prevention and treatment of delirium. In animal models, dexmedetomidine administration reduces the expression of the inflammatory mediators and microglial activation and neuroapoptosis. There are studies, meta-analysis of 67 studies have found that intraoperative dexmedetomidine administration is associated with significantly lower concentration of the stress hormones, CRP, and tumor necrosis factors after surgery. In addition, sleep disturbances is commonly associated with delirium. A small clinical trial reported that post-operative low dose of dexmedetomidine infusion increases the duration of sleep and the duration of the vapor sleep. Coming to surgical trauma, it is thought that surgical trauma can result in both acute stress response and systemic inflammation. In addition, higher incidence of post-operative delirium are mostly reported in association with complex surgeries. Minimal invasive surgeries have been shown to reduce post-operative pain and stress response and inflammatory response in the post-operative period. However, current studies regarding delirium is conflicting that with some observational studies reporting lower risk of delirium with minimal invasive surgeries and other non-minimal invasive surgeries reporting no difference, which needs to be evaluated. Coming to next topic, next thing, perioperative medications and delirium. In perioperative period, generally we use benzodiazepines, which for angiolisis, and carbapentins as a preemptive analgesic, and scopolamine. Some they will use for antiemetic action. All these drugs will increase the chance of occurrence of the delirium. Benzodiazepines will increase the chance of occurrence of delirium in postoperative period by 2.5 times when compared to non-using benzodiazepines. Gabapentins such as pregabalin have been shown to be effective as analgesic adjuvant for acute postoperative pain and may reduce postoperative opioid requirement. However, a large observational study has reported that perioperative gabapentins are associated with slightly increased risk of delirium. This needs to be balanced with opioid-free benefits. Coming to scopolamine is anticholinergic antiemetic. It also can increase the chance of occurrence of delirium, so it can be avoided. Coming to ketamine in low dose is having no significant effect on occurrence of delirium, so we can use safely ketamine in the perioperative period. Coming to choice of anesthesia and its implications in delirium. Recently thought that general anesthesia is having more chance of occurrence of delirium when compared to regional anesthesia, but recent studies showed that there is no, even though the occurrence is more in general anesthesia group, but that is not statistically significant. So it can happen in general anesthesia and regional anesthesia, which is statistically not significant. Coming to options in general anesthesia, it can be given by volatile or IV anesthesia. They found no significant difference in the risk of delirium between volatile and IV anesthesia groups. Coming to Xenon, Chirana, a fashionable anesthetic, thought expert hypnotic effects primarily through inhibiting NMDA glutamate receptor activity via interaction with glycine binding site. And minimal REO concentration is 63 to 71% in clinical practice. However, it is commonly used in conjunction with other IV agents only. It's not used as a sole agent. There is one clinical trial of 42 patients undergoing off-pump coronary artery bypass surgery, which showed that sevoflurane anesthesia is associated with slightly higher post-operative delirium when compared to Jinan group. Coming to next thing, avoid hypodermia. Intraoperative heat loss is a common and associated with coagulation dysfunction and cardiovascular immunological changes. A small observational study reported that patients undergoing cardiac surgery, those with post-operative delirium was found to have lower intraoperative temperatures, but this is also not statistically significant. But hypothermia patients are having more chance of developing delirium. Coming to intraoperative hemodynamic management, the subclinical cerebrovascular events have been implicated in the development of the postoperative delirium, and intraoperative hemodynamic fluctuations may result in the transient cerebral hypoperfusion, especially in the watershed areas, and it will cause delirium. However, several large observational studies and recent meta-analysis reported that no association between the intraoperative hypotension and chance of occurrence of delirium. But this hypotension means the temporary short-term hypotension, but the hypotension which requiring the vasopressor support during the surgery in post-operative period are definitely having high chance of occurrence of the delirium. Coming to next thing, blood and blood products and intravenous fluid administration and their implications in the occurrence of delirium. Initially thought that goal-directed fluid therapy will decrease the occurrence of delirium, but recent studies have showed that no significant difference in the goal-directed fluid therapy and non-goal-directed fluid therapy, both are same. But the allogenic blood transfusion is sometimes required the event of the significant anemia or blood loss. However, it is known that transfusion of the processed and stored blood can trigger significant systemic inflammation, and it will increase the chance of occurrence of delirium. More notably, several observational studies found that intraoperative allogenic blood transfusion is an independent risk factor for post-operative delirium, and there is a dose-dependent relationship between the volume transfusion and the risk of post-operative delirium. And other thing is that the difference between crystalloids and colloids. There is no difference between occurrence of delirium when you use crystalloids and colloids. Coming to post-operative interventions, the non-pharmacological prevention, non-pharmacological delirium prevention is the mainstay of the treatment in the post-operative interventions for occurrence of delirium and prevention of delirium. This is the first line preventive intervention for post-operative delirium are the non-pharmacological interventions. Reorientation is the main aspect in this non-pharmacological prevention. A clinical trial has shown that reorientation alone can reduce the incidence of delirium by 40%. Other non-pharmacological interventions include cognitive exercises, vision and hearing optimization, sleep optimization, mobilization of the patient, good hydration of the patient, and maintaining good nutrition will decrease the chance of occurrence of the delirium in these patients. Coming to melatonin receptor antagonist. Melatonin is a hormone involved in the sleep regulation and is used pharmacologically to normalize, consolidate the circadian rhythm. A recent meta-analysis reported that perioperative melatonin administration is associated with 40% lower risk of developing post-operative delirium. Melatonin is a synthetic and highly selective melatonin receptor agonist. Similar to melatonin, melatonin is also effective in reducing risk of post-operative delirium. Coming to dexamethasone. So as most of the delirium is due to urine inflammation, so they tried using steroids in many of the studies. This is regarding dexamethasone. Dexamethasone is a synthetic steroid which is commonly used in intraoperatively for nausea and vomiting prophylaxis. Corticosteroids are often used for the treatment of neuroinflammatory diseases. Administration have been shown to reduce astrocyte and microglial recruitment and inflammatory mediator expression. In a recent meta-analysis of the 3 cardiac surgery trials, reported that high dose of dexamethasone is associated with moderate reduction in incidence of post-operative delirium. However, the safety profile of such high dose of dexamethasone used in non-cardiac patient is not clear. Antipsychotics are dopamine antagonists and also have varying degrees of affinity to muscarinic, serotonin, and adrenergic receptors. They are divided into first generation, second generation. First generation are associated with higher risk of psychomotor complications, and second generation are associated with higher risk of cardiovascular and metabolic complications. Several studies and meta-analysis have reported that prophylactic administration of second generation antipsychotics such as olanzapine, risperidone may reduce the incidence of post-operative delirium. Because of the risk of complications, the clinical value of antipsychotic prophylaxis is not clear. Management of the established post-operative delirium. In the clinical setting, diagnosis of the post-operative delirium can be challenging as delirium may present as agitation or withdrawal and tend to fluctuate significantly. Formal neurocognitive assessment are time-consuming and often only used by specialists. Instead, several abbreviated methods have been used for diagnosis of delirium. Rule out other agents that mimic delirium by radiological and hematological and biochemical assessment initially. The assessment tools includes confusion assessment methods and delirium observation screening scale. Despite of the availability of the diagnostic tools, delirium is commonly misdiagnosed as depression and dementia. The first line of treatment of post-operative delirium is assessment and management of the underlying cause. This may include infection, pain, correction of dehydration, correction of metabolic derangements, constipation, and urinary retention. To date, there are limited pharmacotherapy options are available for the treatment of delirium. Benzodiazepines were used in the past as symptomatic treatment for agitation in hyperactive delirium. However, it has been increasingly recognized that benzodiazepines may worsen the symptoms of the delirium. Antipsychotics are currently used as first-line treatment of agitation. Some earlier clinical trials have suggested that antipsychotics may reduce the length of the delirious symptoms. This has, however, been refuted by several recent meta-analyses. Delirium symptoms, not they reduce the adverse outcomes associated with the delirium. Can be summarized that there are currently limited treatment options available for the overt delirium. Although antipsychotics are commonly used to manage the symptoms of agitation, they don't alter the time course of the delirium nor modify its prognosis. As such, risk reduction is the most vital part of the post-operative delirium management. Research in the recent years has uncovered more regarding its pathophysiology, although this has not yet yielded effective treatment. We therefore can summarize that post-operative delirium is the best managed by pre-operative risk reduction. Whenever possible, high-risk patients or other undergoing high-risk surgery should be assessed and their delirium risk should be quantified. Effective intraoperative measures in minimizing the risk, delirium risk including the BIS guidelines, guided anesthesia and multimodal opioid-sparing analgesia and intraoperative use of dexmedetomidine can reduce the chance of occurrence of delirium. Post-operative measures include non-pharmacological interventions in melatonin can be used in decreasing chance of delirium. Thank you.
Good morning, Kiran sir. It was a wonderful class, sir. Hello. Hello.
వినపడుతుంది.
జగ్గు వినిపిస్తుంది.
Sir, just I would like to add few points, especially when we are dealing with non-cardiac cases. Follow 3A rule, that is age, albumin, and anemia for evaluation of post-operative delirium, especially for non-cardiac. For cardiac cases, there are n number of list around. There are 14 parameters we have to look into, like age, previous MI, previous CVA, another hypertension, diabetic. There are a lot many. But for non-cardiac cases, in short, 3As, these will be helping us. And one more thing is, there are two scales, sir, especially in preoperative and post-operative assessment of delirium. For preoperative, there is a specific scale called specific activity scale, and another one is confusion assessment method. In as of now, CAM, that is confusion assessment method, is being used widely, which has around 10 domains, and most commonly 4 domain scale, which is a minimal. It's called minimal CAM, that is minimal confusion assessment method, which has agitation, confusion, orientation, and alertness. Minimum parameters which they observe. Coming to post-operative, once we have assessed it slightly delirium, we have to look into diagnostic statistic manual. Same, we will be observing attention, confusion, and is there any change in the patient's behavior preoperatively and post-operatively. These are minimum scale. And one more scale is intensive care delirium screening checklist, which has 8 domains, in which confusion, attention, alertness, hemoglobin, albumin levels, and interaction, all these are parameters. Yes, sir. And question to DNB students, Sir told about first generation and second generation antipsychotics. What is the difference between first generation and second generation antipsychotic drugs?
Jaggu? Hello? I have 3 doubts. First doubt is, it was said that cerebral perfusion pressure, if it decreases with 10 mm of Hg, there is some percentage of increase in chance of delirium. Right? Hello?
Yes.
Yes, sir.
Yeah.
Yes.
Yeah. And you said hypotension has no effect, has minimal effect on delirium. These two are right, as you said in the presentation.
Sir, transient hypotension is not having any
no.
significance, sir.
So what should be the map? What should be the target map to prevent post-operative delirium? That's my question. That's my doubt actually. That's not my question actually. It's my doubt. And another thing is, you said you should use second generation antipsychotics to prevent post-operative delirium. You have to prescribe second generation antipsychotics preoperatively.
Yes, sir.
Right?
Yes, sir.
So in what patients we will prescribe them? High risk groups. Okay.
Yes.
And how will you categorize it? I mean, as he told in the last, will you use the AAA rule, or is there anything specific for that?
Along with that AAA rule and everything, case and surgery condition, which type of surgery we are going, how much blood loss we are going to anticipate, and how many comorbids the patient is having. If the patient is having many problems, we have to use.
And my last question is inflammatory mediators, what are the inflammatory mediators that are associated with this? I missed that point. That's what.
Yes, sir. Actually, there is large debate on this. Actually, main delirium is hypothesis that inflammatory mediators, increase in the inflammatory mediators in the perioperative period will cause delirium.
Yes.
So they start using steroids as in COVID. So to suppress the inflammatory markers, they start giving steroids.
Okay.
The studies that are done previously in 2000 up to 2016 showed that the use of steroids is having no benefit when compared to non-using group. But in recent studies that showed that after 2017, there are 2 to 3 studies. And there is one more study called STRIDE study, I think for spine surgeries. They start using dexamethasone in these patients. And they observed that the occurrence of delirium in these patients are relatively less when compared to non-using group. But they also not yet concluded. The outcome is not finalized, sir. But there is a chance of other problems like wound healing and high sugars and other problems should be timely managed and should be balanced. Risk-benefit ratio you can use. That's what they said.
Okay. Thank you. That was a great presentation. Thank you.
Sir, Kiran sir.
Hello, Kiran.
Hello.
Hello.
One thing about the fluid you mentioned, na, sir.
Yes.
Fluid. It's like short duration surgery with long duration of IV fluids are more prone to have this delirium, sir, than long duration surgeries with the IV line. Since I have read this somewhere. Short duration procedure with long duration of IV fluids post-operatively.
Short duration surgery with long duration of IV fluids will have more chance for delirium.
Yes, sir. They are having more chance of having delirium, sir. And one more thing, sir. I've read about Qutipin. I think means around 2014, around the study was published. It's about comparing haloperidol versus Qutipin, where they have suggested that post-operatively it's better to start with 25 mg Qutipin in post-operative period if you are suspecting delirium. Are any seniors are using any sort of Qutipin in their ICU or else post-operative period? Can anyone comment? Because I never used this.
Another madam, nice to tell, because they will do more cardiac patients and they will do high risk patients. More volume they are having.
Hello.
Hello, madam. Madam.
Good morning. Actually, post-op cardiac cases, we are seeing more delirium cases.
Yes, madam.
Maybe hypoactive or hyperactive or mixed type. So yes, most of the cases is hypoactive and that is dangerous only. So hyperactive means we can see and recognize as early as possible. We can start the drugs. You told about the first generation and second generation. No, first generation is haloperidol. We are using that drug haloperidol immediately. Now second generation Qutipin. So already antipsychotic drugs and during PAC is too much is that means this patient will go post-operative delirium. So you can start directly that drug Qutipin. But I'm using haloperidol only. But I have to change the Qutipin. Next, second, this is the post-operative cognitive dysfunction. No, it is divided into 5 types. Number one is a normal aging. Second is MCA. That means mild cognitive impairment. Third one is dementia. Fourth one is delirium, and fifth one is post-operative cognitive dysfunction. Dementia, it is dangerous and not reversible. But delirium, it is reversible.
Delirium reversible, but it can lead to dementia if we not treat properly.
Yeah, if you gone to dementia, that means he's a bad condition. Thank you.
Good morning, Anuradha madam.
Hi, good morning, sir.
Madam, nothing. Just want to mention one point about haloperidol. So previously, as you mentioned, the first generation antipsychotics were being used, especially haloperidol, because of which what you call increasing risk of QT prolongation, and they had some cardiac issues, and they had too many extrapyramidal side effects, because of which they have shifted to second generation, which is Qutipin. Though Qutipin is told bit advanced, but still it has almost what you call equal amount of side effects as haloperidol. So better suggestion is maximum try to avoid using any pharmacological interventions for delirium. But if you are left with no option, go with second generation. And sir, Kiran sir, one more point. Did you see any study in 1998? I think there was a study showing that use of opioids, especially morphine, is associated with increased number of what you call post-operative delirium cases. But recent any update on opioid and delirium, sir? Anything you came across?
Omkar, compared to midazolam and dextromed, midazolam more causes of delirium. So better to avoid midazolam and use dextromethorphan. It reduces the delirium in post-operative.
Okay, madam. And the use of opioid, especially nowadays, people are more of fancy about using fentanyl patches and more of intraoperative fentanyl infusions. Just one information. Did anybody come across this? Opioid and
using more about the pain, analgesia only.
Whenever possible, we try to avoid opioids if possible. If not possible for pain management, when other aspects are not sufficient, then we have to use opioids. Pain itself can cause delirium. And regarding paracetamol, there is 2 to 3 studies are there. Intraoperative and post-operative usage of paracetamol, 1 gram TID will significantly decrease the delirium. That papers are also there. Regarding opioids, means they are saying use multimodal analgesia whenever possible, decrease the chance of using opioids or decrease the dose at least. Provided pain should be taken care of by other measures. If pain is not taken care by other measures, we have to use fentanyl or morphine, because pain itself can be more damaging. Pain itself can cause delirium. Pain itself can cause stress response.
I mean, multimodal analgesia means of opioids. I mean, fentanyl and dextromed and paracetamol combination you can use reduce the pain. Only single drug fentanyl means I think it's not reducing.
Especially if a patient is having any CKD or CLD coming to some other surgeries, non-cardiac surgeries, for post-operatively, most probably we go with fentanyl infusions. So that's what I had a doubt. Is that causing any increase in number of delirium? Anybody observed or not?
We have that much of time to observe the patient.
Sir, good morning. I have 2 questions to DNV students. What is the difference between hallucination and delirium? Number 2, in which age group the ketamine-induced hallucinations are common, and in which sex?
Hello. Good morning, sir. Hello. Hello.
Hello.
సార్ మీరే చెప్పండి సార్.
Hallucinations are abnormal perceptions of sensory organs. అంటే తాడుని చూసి పాము అనుకోవటాన్ని అలా ఆబ్జెక్ట్ ఉంటుంది హాలుసినేషన్ లో. డెలీరియంలో దేర్ ఇస్ నో ఆబ్జెక్ట్. Ketamine induced hallucinations are common in young females, mostly auditory.
సార్ మిస్టేకింగ్ ఆబ్జెక్ట్ లైక్ అంటే తాడుని చూసి పాము అనుకోవడం ఇల్యూషన్ అనుకుంటా సార్, హాల్యూసినేషన్ కాదు.
అంటే hallucination means the perception of something is not present కదా.
Yes madam.
So
Abnormal perceptions of the special senses. There is visual, auditory and olfactory.
ఎస్ సార్. అంటే పిచ్చి పిచ్చి సౌండ్స్ వినబడతాయి, పిచ్చి పిచ్చిగా ఏదో ఆలోచిస్తుంటారు. నెక్స్ట్ వీ హ్యావ్ లాట్ ఆఫ్ ఎక్స్పీరియన్స్. అంటే ఒక పేషెంట్ అయితే బెడ్ నుంచి ఐసీ జంప్ చేసేసి ఆల్మోస్ట్ సెక్యూరిటీ గార్డ్ దగ్గరికి వచ్చేస్తే స్టాండ్ పట్టుకొని పరిగెట్టారు. ఆ స్టాండ్ కి గ్లాస్ బ్రేక్ అయిపోయింది. అనెస్థెటిస్ట్ డ్యూటీలో ఉంటే ఏంటి సౌండ్ అని ఓపెన్ చేస్తే ఇంకా ఎదురుగా స్టాండ్ పట్టుకొని ఎదురుగా ఉన్నాడు. అంటే ఇంకా ఇమాజిన్ చేసుకోండి, అంటే ఆ స్టాండ్ ఏదైనా కొట్టచ్చు, ఆ టైప్ లో ఉన్నారు. సో ఆఫ్టర్ 5 days తర్వాత he realized and everything and he told sorry because I'm somebody is pushing like this and పికప్ ఇసుకేయడము ఏవో చేసేసి నా మీద పడేస్తున్నారు, అందుకని నేను అలాగయ్యానేమో ఆ టైంలోని చెప్పాడు.
We are using haloperidol in atropine-induced psychosis in OP poisoning also.
సార్ నాకు ఇంకొక డౌట్ సార్, కోవిడ్ టైంలో ఐసీయూ సైకోసిస్ కి నాన్ కోవిడ్ టైంలో ఐసీయూ సైకోసిస్ కి ఏమైనా డిఫరెన్స్ ఉందా సార్? అంటే ఇన్సిడెన్స్ లో డిఫరెన్స్?
కోవిడ్ టైంలో డాక్టర్స్ కూడా వచ్చింది సైకోసిస్.
కరెక్టే.
పేషెంట్స్ కి
అంటే కోవిడ్ అంటే ఆ టైంలో అన్టచబుల్ పీపుల్ కదా, సో ఆ సైకోసిస్ అయితే ఇంకా డిఫరెంట్.
I have a little doubt. Is risperidone is a better alternative to quetiapine? Is there any comparative studies there using quetiapine and risperidone for post-operative delirium?
Both are second generation only, but
both are second generation only, madam. But quetiapine is associated with QT prolongation.
Yeah.
But risperidone doesn't. So that's what I am asking, because most of the delirium patients we see are cardiovascular thoracic surgery patients, that too prolonged cardiovascular thoracic surgery patients. That's why, is there any study comparing risperidone and quetiapine in post-operative treating post-operative delirium in cardiovascular thoracic patients? That's what I'm asking.
I have no idea, sir. I will go through and I will come back.
What is the onset of action when you use first generation and second generation antipsychotic drugs?
Onset immediate in first generation, sir.
Sir?
Onset is immediate.
Immediate.
Second generation injectable or tablets?
Tablet form.
Tablet form.
Yes, sir. First generation we have injectables.
Inject both injectable.
Both.
Are there? And tab serenase and injection serenase. So we can dilute and give slowly injectable. And tablet 5 mg.
కాదు మేడం, ఇమీడియట్ యాక్ట్ చేస్తాయా లేకపోతే ఇప్పుడు ఆల్ యాంటీ డిప్రెసెంట్ దే యాక్ట్ ఆఫ్టర్ 24 to 36 hours?
సార్ నాకు నో ఎక్స్పీరియన్స్, ఓన్లీ సెరెనేజ్ అయితేనే ఐడియా ఉంది. ఇట్ టేక్స్ 5 minutes టైం, మోర్ దెన్ 5 minutes.
క్విటిపిన్ మేడం?
నో ఐడియా సార్. టాబ్లెట్ కదా, నాకు ఇంజెక్టబుల్ ఐడియా లేదు. అంటే నేను కేషీట్ లో చూడడమే కానీ ఐ నెవర్ సీ మై ఎక్స్పీరియన్స్.
కిరణ్ షుడ్ బి ఏబుల్ టు.
నాకు కూడా తెలుసు, హాలోపెరిడల్ తెలుసు.
we are using haloperidol only.
మా దగ్గర ఈ సైకియాట్రిస్టులు క్విటిపిన్ పెడుతున్నారు, కానీ అది యాక్షన్ ఎంత ఇమీడియట్ గా ఏం రావట్లేదు, స్లోగా వస్తుంది. మరి అంటే నేను లిటరేచర్ చూడలేదు కానీ.
అంటే టాబ్లెట్ దట్ వన్ యూఆర్ యూజింగ్ నైట్ హెచ్ఎస్ కాబట్టి ఆఫ్టర్ డిన్నర్ వెన్ యూఆర్ పేషెంట్ స్లీపింగ్ దట్ టైమ్ యూఆర్ గివింగ్ నో. సో వీ డోంట్ నో ఎగ్జాక్ట్లీ. సో serenase also I'm giving night only. If I'm thinking delirium confirm means I'll give a BD dose.
Any interaction with of these antipsychotic drugs with antihypertensive drugs, MAVA inhibitors?
మీరు చెప్పండి సార్, మర్చిపో.
డ్రగ్ ఇంటరాక్షన్స్ లో మనకు ఒక ఇది ఉంది కదా, మావో ఇన్హిబిటర్ షుడ్ నాట్ బి గివెన్ విత్. నాకు కూడా కరెక్ట్ గుర్తులేదు సార్, చదివినట్టు గుర్తు. ఓంకార్ షుడ్ బి ఏబుల్ టు టెల్ రీసెంట్. సార్ ఎనీహౌ ఐ విల్ రెఫర్ అండ్ టెల్, పుట్ ఇన్ ది గ్రూప్.
ఓకే సార్.
Okay then, chalo. Shakhar, next week it's DNB class. Please coordinate and.
Yeah, I'm there.
Yeah.
Yeah.
Next week DNB class re. ఎవరు చెప్తారో కనుక్కొని ఒకసారి మెసేజ్ పెట్టే.
ఉన్నదిద్దరే ఎవరో ఒకరు చేసేస్తారు, చెప్తాను ఇట్లే. రైట్.
ఓకే రా. బై. ఓకే then, chalo. Bye.
Thank you, Kiran.